Hello and good evening, and thank you everyone for joining us. This is the series of webinars on updates on glycemic control biomarkers. This is our sixth webinar. It's being organized by the Emory Diabetes Training Academy. This is the last seminar, and I have the pleasure to have two world-renowned speakers. We're going to be discussing today the role of glycated albumin and complications. And the first speaker, many of you already know him. He's Dr. Vivian Fonseca. He's the Assistant Dean for Clinical Research at Tulane University. And also professor of medicine there and the chief of the division. He's been on the board of directors of ACE and also a past president of medicine and science of the American Diabetes Association. When we prepared the program, we were trying to locate speakers with expertise in the use of glycated albumin, and his publications immediately pop up because he had many publications on the topics. He's done many of the validating studies, so it is a great pleasure to have our great colleague, Dr. Fonseca, joining us. Welcome in, Dr. Fonseca.
Thank you very much, Rodolfo.
Then trying to prepare the program was, it took some time, and then trying to find experts, we located Dr. De Souza, who trained at Tulane years ago, but he's now a professor of medicine at the University of Nebraska and the chief of the division there, the Division of Endocrinology. He's been doing a great work also on biomarkers. He's done many of the validating studies, very interesting research experiments on the use of glycated albumin. So both of them are going to be doing a brief presentation, like a formal presentation on the topic. And then later we're going to have a debate. Or maybe, I mean, we probably all agree on the topic, so it's not going to be too much debatable, but at least we're going to be giving three different point of views. So that was one of the thinking, that the more people we have, create. So everyone, thank you for joining. That is very late for some people and very early for others. So thank you for joining. Let's just begin. And this is again the series of webinar of updates on glycemic control biomarkers. Thank you very much, and let's just begin.
So thank you, Rodolfo. Thank you for that kind introduction. And, we are today, the main purpose of today is to recap some of the key points of some of the previous lectures on these biomarkers that we've had in this series over the last few months, and then answer questions. Some questions have been sent in. I'm sure some of you will put some in the chat box, and then we will have a good panel discussion. So I'm going to very briefly go through some of the points that were made in the lectures that I did, and Dr. De Souza did another one to talk about some of these biomarkers. So let me share my screen. So really, we are trying to, this is a very new test, and we are trying to identify the place of glycated albumin in practice. It has become available very recently, approved by the FDA. It's available right now through LabCorp, but we hope through others as well. So let me move ahead. So first of all, we've used hemoglobin A1C for a long time now. It really established itself very strongly in the DCCT trial, where it was an excellent marker of long-term complications of diabetes. And more importantly, it was shown that if you reduce A1C, you actually improve the outcomes. So this was seen for multiple complications. Here's retinopathy, and really this was all about A1C. But there was subsequently a lot of people felt that A1C reflects average glucose. But there's been some controversy that was done in a small study, self-monitoring of blood glucose. A few people had some of the older CGM. So there's some limitations to A1C. And one of the big limitations is the intra-individual A1C variation. Despite glucose being constant, some people fluctuate up and down. There are also biological variabilities in A1C between individuals, and that can be very challenging. And there are a number of characteristics. So my colleague, Dr. Hempy, who has worked with me over many years, pointed out very early that African American children had different A1Cs for the same level of glucose than white children, and this we have confirmed this in multiple other studies. And so there's a variation in A1C when you control for blood glucose. Other people have pointed this out. There's a difference between predicted A1C when you do the mean blood glucose calculation and the actual observed A1C. And some people call this the glycation gap. And actually, there's an interesting concept. It might reflect some people who have a large gap might be overglycating, and they might be at greater risk of getting complications. So that's an interesting thing, but it presents with a practical problem in everyday clinical practice that I'm sure you recognize from time to time, that the A1C is not reflecting the blood glucose that the patient is measuring. And that can occur, and certainly it's been recognized things like anemias and chronic kidney disease, but also other situations. I mentioned the ethnic difference. So it also, A1C is a mean of a reflection of 2 to 3 months of glucose control. It doesn't measure variability very much. It doesn't tell us about hypoglycemia. So it's come under a lot of criticism. Glycated albumin, on the other hand, is a glycation of albumin that's very specific for albumin, that is not dependent on anemia. So hemolysis, hemoglobinopathies don't really matter. We've used fructosamine in the past, and I'll show you the difference between the two. There's a lot of fluctuation in fructosamine. Glycated albumin has a lot less than that. And it reflects the glycemic control over the previous 2 to 3 weeks because of the much shorter half-life of albumin as compared to hemoglobin. And we may have some data on glucose fluctuation. I know that Cyrus might be talking about it. We looked at it in the studies we did together, and we'll see what this shows. So A1C is not recommended according to the ADA's guidelines, and also from the clinical chemists in certain situations that you know very well, and I've already mentioned, so I won't repeat that. And glycated albumin might be an alternative test in that kind of situation. So why are we doing this right now? So many years ago, glycated albumin was described, but there was a very cumbersome lab method that was expensive, difficult to do. And in the last few years, our colleagues in Japan at Asahi developed an automated assay that made it very easy to measure glycated albumin. And that is what has actually now been approved, and should be easier to measure than actually even hemoglobin A1C. So it's can be useful in clinical practice. So what's the difference between GA, called glycated albumin, GA, and fructosamine? Fructosamine reflects all proteins and their glycation, whereas GA is only albumin. Now, one of the problems with all proteins is that you know that they fluctuate a lot. Immunoglobulins go up when you have an infection. So the percentage might be of the total protein might be less of glycation, and then it might change the following week. So you get a lot of fluctuation in some people from time to time with fructosamine that you don't get with glycated albumin. So fructosamine is the glycated protein test, whereas glycated albumin is specific. Now, there are differences in methodology, etc., that we talked about during the earlier lecture I did. I won't go into that right now. There are some other differences in terms of measurement. Fructosamine is reported as micromoles per liter, whereas glycated albumin is reported as a percentage, like hemoglobin A1C. And there's a lot of standardization now that is available for glycated albumin. And there's a lot in the literature about the value of GA to predict microvascular complications, macrovascular complications, all those kind of things, and its use in dialysis patients that has been discussed in this series of lectures, and I'll touch on very briefly. So a few years ago, Dr. D'Souza and I did a small study, which he'll describe in more detail, but what it showed is if you make an acute change in somebody's treatment, it takes a long time for the A1C to change. And today we have very expensive treatments, and if you wait 3 to 6 months to see the A1C change, and it's not working, you won't know for a while. Whereas with mean blood glucose, you could get it quickly, but that is cumbersome for the patient. But glycated albumin actually changes very fast. So here's a comparison between 7-day blood glucose in green, fructosamine in orange, and glycated albumin, as well as A1C. And you can see that uh, the glycated albumin is very stable in terms of the rate of change, and it actually predicts A1C in about 3 to 4 months extremely well. You can see in a particular patient here that Dr. D'Souza described, somebody with marked fluctuation in fructosamine that did not happen with the glycated albumin. So we don't know whether it's infection or something else in that particular individual. Now, you're hearing a lot about CGM metrics and time in range, etc. So I want to point out a very recent paper from Japan that shows that time in range over the previous 2 weeks on CGM correlates fairly well with glycated albumin in both type 1 and type 2 diabetes. There's a lot of controversy because it doesn't really correlate well with A1C, and that's not surprising. You have a time in range is the point in time in these last couple of weeks when your patient is wearing the CGM, and we don't know what's going to happen in 3 months' time, whereas glycated albumin is very similar. So there's some similarity here between an acute metric from CGM and glycated albumin. Now, you also heard other lectures. Dr. Selman and others presented data from epidemiological studies. First of all, in the DCCT, they went back and measured glycated albumin, and it was pretty good, very similar to A1C in terms of prediction of outcomes. In the ARIC study, it similarly predicted retinopathy, nephropathy. In those with pre-diabetes, it predicted incident diabetes, and so on. So here's the DCCT data, and the conclusion from this article was that both A1C and glycated albumin were related to microvascular complications. So it's a good predictor of future complications, very similar to hemoglobin A1C. And here is people with renal disease, again, showing that both A1C and glycated albumin correlate well. There seems to be a lot of variability in the A1C. There is some with the glycated albumin, particularly in people with severe nephrotic syndrome, but those without a lot of proteinuria, this might be very stable and reasonable. So just a comparison between the 3 tests in summary. A1C is within the red cell, GA and fructosamine are in the whole body. They're reported differently. They reflect different time courses of glycemia, but they have their strengths and limitations. The strength of A1C is the gold standard, and it's been used for a long time. It's approved for diagnosing diabetes. But in situations where it cannot be used, like anemias and hemoglobinopathies, it's a problem. Pregnancy, it's a problem. And glycated albumin has been shown to be useful in those kind of situations. There are limitations there too, and when you have albumin problems, like mainly nephrotic syndrome, but occasionally liver cirrhosis, and very rarely in hypothyroidism, you might have some problems. Now, people ask the question, how does this relate to A1C, between A1C, average glucose? Now, we know that an A1C of 7% actually reflects an average glucose of about 150, and the GA would be 20. So if your goal for a patient is A1C less than 7, your goal for GA would be less than 20. Now, this is based on some previously published data from the study that Dr. D'Souza and I did. We've actually now started looking at the data. There have been some delays in doing that, but I'm working with my colleagues in Japan to do this, and we might come up with an updated nomogram like this. But right now, this is what we have, and we will try to get this update put out there. So in summary, over the last few months, you've heard that A1C is a good test for glycemic control. It predicts complications very well. Changes show that you can reduce the risk if you reduce the A1C, but there are limitations. So we've looked for alternatives in those situations. Glycated albumin, fructosamine, similar, but maybe glycated albumin is a bit more stable. Self-blood glucose monitoring, which, as you know, has huge limitations because it's just simple points in time. I think CGM is great. It has really transformed how we practice clinical diabetes, but it is somewhat expensive and cumbersome for the patient, somewhat challenging. And for some people, it is absolutely essential. For others, you might get similar kind of information from time and range, at least from glycated albumin. It's now available as a simple automated test, correlates very well with complications, and can be used in some populations where A1C may not be reliable. I personally like the concept that it may be useful in evaluating the success or changes in therapy. So you start somebody on a new treatment, you call them back in 2, 3 weeks, you do the glycated albumin, and you know that it's working if it has dropped. And if it hasn't, maybe you need to change direction again. So I'm going to stop there, and I'm sure you will have questions about all these things. I'll hand over to Dr. D'Souza, and then we'll both all come back for questions. Thank you. Let me stop sharing my screen.
Thank you, Dr. Fonseca, for such a great presentation. As I say, so our second speaker is one of the international experts on the topic. He's done many of the validating studies, and he's a professor of medicine at University of Nebraska and the chief of section of the endocrinology section there. He's Professor Dr. D'Souza. Thank you, Cyrus, for collaborating with us and presenting your data. Thank you so much. Let's just learn from you.
Thank you for having me, and pleasure to be here. Good evening, everybody. So I'm going to try to complement what Dr. Fonseca just showed you. And here are my disclosures for this particular lecture. So we're going to try to discuss the ability of glycated albumin and fructosamine to predict some diabetes complications. I think Dr. Fonseca showed you a brief slide about that. I'll go a little more detail into that. We look at some clinical settings where glycated albumin might be very useful, such as insulin titration, medication changes, or during pregnancy and gestational diabetes, or in chronic disease. So, as Dr. Fonseca mentioned before, although this slide was not shown, but as you go from a normal person to a person with type 2 diabetes and microvascular complication, you do notice that there is a relationship between complications and glycated albumin. This is what this slide shows. And this is the slide which was shown to you prior, but there is a very strong sort of correlation between glycated albumin, fructosamine, and A1C in terms of microvascular complications in several studies that were discussed before. In terms of macrovascular disease, we also actually have evidence that glycated albumin, fructosamine, and A1C have these correlations in terms of predicting complications. For example, in the ERIC study, it was the heart failure and mortality, while surrogate markers like carotid IMT, and that's intermittent media, was shown in one other study in 2015. And the major cardiovascular events was also shown to be associated with these markers. And here are some more details. You can see that the solid lines are sort of the average and the dotted lines are the confidence intervals. The column, the first column is heart failure and the second column is all-cause mortality. And we see that in A, we have a relationship of fructosamine to heart failure, which is sort of a J type of curve. That means it's slightly higher on one and the very low end is slightly higher at the very high end. This is similarly seen in glycated albumin figure B and also in figure C, more or less. So you can see there's a pretty good correlation between the three markers in terms of relationship to heart failure. And in the second column is all-cause mortality. Similarly, in D, fructosamine, and in E, glycated albumin, and in F, hemoglobin A1C, all three show you a similar sort of J-point curve where it's lower on the lower, higher on the low side. Then there's an optimal area of control. And then there is, as these three markers get high, the all-cause mortality goes higher. The lower point of the curve might indicate that the person is very sick. So it might indicate the sickness of the person rather than the indicator itself. So, it was proposed by Nathan et al. That perhaps we could come up with a combination of predictors that would predict complications in the short, intermediate, and long term. If we were to combine like a CGM or a plasma glucose with glycated albumin and hemoglobin A1C. Now, we don't have anything official like that, but a development of such a composite marker would be very useful to predict complications. So next we talk about some clinical scenarios where glycated albumin is useful, and I'm going to move directly into them. So, we do know that the ADA has suggested, like in some situations like chronic renal failure, glycated albumin is much better. And in those conditions where there's lots of glycemic excursions, which means variability. As you know, two people with the same A1C may not have the same CGM profile. They may have very differing glucose values at different times. So that brings me to this slide where you can see that this is SMBG, is the subcutaneous glucose that most patients will measure, and CGM is the continuous glucose monitor. They each correlate with each other really well. But what you can also see in this slide is the huge bars that you can see that go up and below those dots and triangles. That is the variability of this indicator. So you can see it's hugely variable, and that therein lies one of the problems because of the high variability. Now, as Dr. Fonseca was saying, we did some studies and we looked at what are the different relationships between the different indicators. So in this particular graph, the blue squares is the A1C, and the yellow triangles is the fructosamine. The purple diamonds are the glycated albumin, and then the red round features are actually mean blood glucose. So just let me go into a little bit detail. You can see the mean blood glucose, the red circles. They kind of jump up and down. They go down initially in week 1, and then they go up and then they go down and they go up and they go down. And in week 8, they're back up again. And then week 12, they're back down. So the trend is not very, very clear if you look at that only. Then on the other extreme, if you look at A1C, all you see is just a gradual diminution in A1C. There doesn't seem to be any pattern. It's high in the beginning and it slowly and very gradually and in a nice curve, it comes down. So at 12 weeks, it looks as though your patient just had a very smooth decline in terms of blood glucose. But that, as you know, that's not true, because look at the blood glucose jumping around. But if you look at glycated albumin, it gives you, that's the purple diamonds, gives you a very, very good image of what actually happened with the patient. So the first 3-4 weeks, these people, they lost their, the blood glucose came down, and then there was a slight uptick over the next 4 weeks, which is almost in correlation with the mean blood glucose. And then again, there was a slight downtick in 12 weeks. Could have been the patients had some infection or there was stress in that time. We don't know, but it tells you a little more detail than either the mean blood glucose or the A1C alone would. Next, let's look at pregnant women. That's both GDM and women with pre-existing diabetes. And glycated albumin has been shown to be associated with neonatal complications. Iron deficiency anemia, especially in developing countries, is a big problem, which affects A1C, but it does not affect glycated albumin. So looking at complications, you will see that using 15.8 as a cutoff point for glycated albumin, there was a definite relationship between hypoglycemia in the newborn infant, respiratory disorders, hypocalcemia, myocardial hypertrophy, and large fatigue in people who had higher glycated albumin. So you can see that glycated albumin is actually a pretty good indicator. And 15.8 corresponds to just below 6 around in terms of A1C. So being a good indicator, if you follow A1C versus glycated albumin, so in this, let us first look at A, where the A1C is the dark squares and the glycated albumin is the round dark circles, and the ferritin are the triangles. Now, naturally in pregnancy, the ferritin levels, especially in underdeveloped countries where there is iron deficiency anemia, the ferritin levels will go down as time progresses. This causes an artificial increase in the hemoglobin A1C because of increased reticulocyte count. But you see that the round dark circles is pretty stable, which is the glycated albumin. That is not affected by this particular phenomenon. So it's better, much easily followed than A1C. In B, it's just to re-emphasize the same point that the hemoglobin A1C in dark circles is very much correlated to ferritin levels, and glycated albumin is very stable. No, doesn't matter what your ferritin levels are. So probably a useful indicator in pregnancy. And then in diabetic kidney disease, the problem is that the erythrocyte survival time is shorter. There is also other things like the use of erythropoietin and deficiencies in iron and folate and B6. And these things can influence A1C levels in diabetic kidney disease. And therefore, maybe glycated albumin is a better indicator. The one caveat is that in certain kidney diseases like nephrosclerosis, where you have a large amount of albumin loss, glycated albumin may not be a good indicator in that scenario. So as you can see, the relationship between A1C and glycated albumin, Vivian has mentioned this in his slides. So I'm not going to be, I'm going to be very brief, but glycated albumin has a pretty good correlation in kidney disease in terms of average glucose and glycemic control. That's B and D. While in A1C, which is A, you can see that people in the dashed line, those without CKD, have a distinctly different A1C than patients with CKD in the dark circles and the straight line. So in A, you can see there's a distinct difference in the amount of the value of the A1C with all average blood sugars starting from low to high. So glycated albumin also predicts survival in patients undergoing hemodialysis with diabetes. And if you take a cutoff of 29%, which is around 9 A1C, you will see that there's a distinct survival advantage that is shown with the lower glycated albumin. So we see that this is a good predictor even in renal disease. So in summary, we have glycated albumin that is better at detecting variability. Glycated albumin is expressed as a ratio of the albumin concentration, and so it's reliable irrespective of the actual albumin level. And in some cases cheaper than A1C, but it's probably competitive in terms of measuring A1C versus glycated albumin. Glycated albumin is a really good prognostic indicator for future risk for diabetes, and is very useful in the scenarios that we just discussed, such as titration of some medications during pregnancy and in the setting of chronic kidney disease. So with that, I will conclude my presentation, and we can probably start answering and having a discussion and start answering some questions.